I'm very excited about the IBI 363 trial, the Morslide trial in lung cancer, refractory disease. Previous studies have shown that IL-2 can be very effective in attracting T cells, but it can also produce some toxicities. But here we have a bispecific antibody that has an IL-2 beta sparing function combined with PD-1. So this targets it more to the immune microenvironment and hopefully ameliorates some of the toxicity. We've seen that from some of the early phase 1 work with nice response rates in both squamous and adenocarcinoma of the lung, refractory to prior immunotherapies. So we're very optimistic that this new trial will show us some activity in lung cancer in immune refractory patients, which is, of course, a very difficult group of patients to treat. So I'm looking forward to running this trial with my colleagues, and it's my pleasure to be the steering committee chair. Right now, there's so much positive news in lung cancer. At this ASCO, we hear about Harmony 6 and PD-1 VEGF in the frontline setting. This trial's in the second-line setting, and I think that this trial, randomized trial, looking at response, but also progression-free survival and overall survival, could give us, if positive, 600-plus patients, a new regimen for refractory immunotherapy lung cancer patients. So I think that it's an important trial. It's compared to docetaxel. We're going to recruit around the world, and this could then result in a regimen that has activity. If it does, we'll move it to the earlier setting. But it's a very thoughtful, preclinical development, taking it to the early phase 1 trial, now to the phase 2-3 study. So we're all very optimistic about this. I presented just a trials in progress poster today. The study's just getting underway worldwide. We're starting this at Yale. I'll hopefully open this at Dartmouth College, where I'm going to start my next chapter of my career. So it's all very exciting. Well, we know that immune therapy works in lung cancer. It's transformative. We've seen it here at the ASCO meeting for the last decade. But we know that only about 15 to 20% of patients have the truly long-term benefit. Many are resistant. Either they're primarily resistant or they become resistant. If they're primarily resistant, they might be missing T cells in the immune microenvironment, and this drug is meant to bring them in. Here we're going to take refractory patients. We're going to hopefully use IL-2 to attract T cells. By having the T cells there along with the PD-1 component to block the immune checkpoint, we believe that this will allow the immune system to target these tumors. If that happens, there'll be long-term benefit. That's the goal. That's why we're here. It's about the patient. That's why we're here at the ASCO meeting. My pleasure to talk to you today.